Okay, so first of all, I'd like to thank the organizers for a very interesting conference, and I'd like to thank my co-presenters, who unfortunately couldn't be here today, Ella Holtzman, who is a very senior neuropsychologist in Israel, and Professor Eliezer Witztum. I think most of the Israelis know him as a very famous and well-respected psychiatrist in Israel. So we've heard a lot about demography. I'm not going to go through the aging of the world's population. I always like this particular slide because our colleague from Japan, who gave an excellent talk this morning, isn't here. But Japan shows us actually very well how a country goes from a pyramid soon after World War II with a lot of children and hardly any old people, and they're heading very rapidly, as we heard, to be a pyramid standing on its head with very few children and very, very many old people. So that's what's happening to the world. Israel, as you can see from this pyramid, is considered to be a relatively young country. We have a lot of fertility, we have a broad base, but Israel is actually very different to the rest of the world because we have very high life expectancy. The men are number 5 in the world in Israel, women number 9. But the largest growing population in Israel, which is growing, if the population is growing from 1955 to 2035, 6 times, the population of those aged 75 plus are growing 34 times. Which means that we're getting a very, very rapid increase in the number of very old people. And that's not something you see generally in the world. And the reason in Israel is that there was a very big immigration from the former Soviet Union of well over 1 million people. And a lot of them came in young middle age or middle age, which means they are now aging rapidly, and they put a big boost of old people into the population in Israel. So that's the first point I'd like to emphasize. The second point is my teacher and mentor, Professor Bernard Isaacs from Birmingham in England, wrote a very small little book in 1976 called The Giants of Geriatrics. And what he said is that it's not important to look at comorbidity, diabetes, hypertension, heart disease, things that we usually look at. He said it's important when you deal with old people to look at function. He was the one that really brought to the attention of the geriatric community the importance of function, and he spoke about the 4 big I's: immobility, that an old person can't get around as he could; instability or falling, they fall more often; incontinence; and the 4th giant of Bernard Isaacs was intellectual impairment. He did not realize when he wrote this little book what an epidemic was going to hit the world with the development of cognitive impairment and dementia. So we know that aging is related to that. In aging we get changes in cognition from normal aging, subjective cognitive impairment, where we start to click our fingers. You know what? It's a very well-known sign in geriatrics. What was his name again? You know, you start clicking your fingers, and that's mild changes in cognition until we get to dementia, which is obvious to everybody. And the causes of dementia are many. Vascular dementia is important, where we have brain disease caused by mini strokes or big strokes to the brain. And the most common cause of changes in cognition is Alzheimer's disease, which again is a fascinating topic, and I can't get into Alzheimer's disease now. That's not the purpose of this talk, but Alzheimer's has been around for a long time. It was described by Professor Alzheimer. Here's a picture of him. I'll see if the mouse works. Here's Professor Alzheimer over here. And he described it in 1906, where he looked after this old lady, after our interesting talk from Brazil. This old lady here, Augusta D., had changes in behavior, changes in cognition, and died. And then he took her brain. I'll show in a minute what her brain showed. But how old is Augusta D? Looking at this picture? 51. Okay, she died at the age of 51, and she was considered to be very old. This was in 1906. And what he saw in the brain were two very interesting things. He saw what he called the senile plaque and the neurofibrillary tangle, and this has been around since Alzheimer over 100 years. Today we know exactly what is the senile plaque. Here's a beautiful picture of the senile plaque with a core of beta amyloid, and we know that around the senile plaque there is inflammation and death of other cells, and this is a slowly progressing disease. Today we believe that the disease starts some 20 years before the person says, "What's the name of that person that I saw yesterday?" Okay, so it's a very, very slowly progressive disease. But what's interesting in Alzheimer's disease is it goes through specific symptoms, starting with a little bit of memory problems, eventually problems with other cognitive functions such as orientation, and then somewhere in the middle of the disease, the subjects, the people, develop behavioral problems. Now, how common are these behavioral problems? Today we believe that up to 90% of people with dementia of all kinds, but specifically Alzheimer's, develop some sort of behavioral problems as part of their condition. It's not only memory and orientation. What are the behavioral problems? This is a little bit hard for you to see. There are many things from agitation and apathy and anxiety and sleep disorders and appetite problems. But what I want to discuss with you is disinhibition. They lose their brakes. They can't hold back anymore, right? They become disinhibited. And what I'm going to do is present 3 short case presentations to try and emphasize the type of problems that we faced with disinhibition and sexual behavior of older people. So case number 1 is a 66-year-old man, widower, father of 5 children. I've changed some of the details so that you won't be able to identify them in case you know them. 13 grandchildren. He went on early pension after he had a stroke at a fairly young age. He's got a very bad risk factor profile. He's a heavy smoker and he drinks alcohol quite often. And he's had recurrent strokes. He had a big stroke and then he had a few smaller strokes after that. He has a mild right hemiparesis. He's weak on the right side of his body. And he had at some stage in one of the strokes a transient aphasia. He lost some of his ability to speak, but that came back. And he's got minor memory complaints, but nothing specific that would bother him too much. And there's a legal issue. After he had sexually molested his 11-year-old granddaughter, who told her mother what had happened, and the mother went to the police, so granddad was arrested. And the judge asked for a medical evaluation of this man. The main findings in the neuropsychological assessment of this patient was major disinhibition. The man showed major problems with the inhibition, and he had both on physical examination and on neuropsychological assessment. And I'm going to bring 1 or 2 examples. I can't bring you the whole neuropsychological assessment. An assessment of this type of patient neuropsychologically takes 3 hours or more. Okay? So I'm going to just bring 1 or 2 visual ideas for you to get about how we assess these patients. So here is the famous clock drawing test. The clock drawing test, you give the patient a circle that's 10 centimeters in diameter, and you tell him or her to fill in all the numbers and put their hands on the clock that it should be 10 past 11. You see, I'm starting to... Okay, 10 past 11. So that's the instruction. So what did this man do? He wrote 12 and 6. I'll tell you exactly how he did it because I was watching him. He wrote 12 and 6, and then his eye went back to the 12, and he said, 12. Now, what do I do now? He looked a little bit confused, and then he said, 12. What comes after 12? 13, 14, 15, 16. And then his eye went down to the 6, and he said, wait a minute, that's a bit strange. What comes after 6? Well, after 6 comes 7, 8, 9, 10, and 11. And now he was, as they say in Hebrew, mabsut. He was happy, right? Because he had finished his numbers. And then I said, don't forget you have to put the hands on at 10 past 11, you see. So he then said, oh, yes. So he started, and he put one hand. He started to separate the clock into portions, and again, and again, and again, and again, until I said, okay, that's enough, because he would have carried on. So medically, for those physicians amongst us, there are three important issues. One, obviously, his planning and his what we call executive function is not very good. But more important is he is what we call stimulus bound. He sees a stimulus and he goes for that stimulus. So he saw the 12 and then he wrote the 13, 14. He saw the 6 and then he carried on. So that's called stimulus bound. And the other thing is perseveration. The fact that he started doing hands and hands and hands and hands, so he's perseverating. He goes over the thing again and again. You'll see this in old age homes, in people with advanced dementia. They may sit at the table and hit on the table and go, or they may say, achot, achot, nurse, 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 again and again. That's perseveration. So these are two very clear findings of frontal lobe, the foremost part of our brain, dysfunction. Okay? And the frontal lobe are the brakes of our behavior. That's what prevents all of you getting up and walking out because you don't like my talk. Your frontal lobes are keeping you here. Okay? So those are our brakes. And here, have a look on his MRI, and you'll see that it's actually a CT, sorry. You'll see that he has a previous stroke sitting right in the frontal lobe on the right-hand side. So this is a patient with clear brain disease, and he's had a stroke affecting his frontal lobe, and his behavior is frontal lobe dysfunction, which is disinhibition, and that can go fairly well with the fact that he molested his granddaughter. Okay, so let's go back to the court, and the court in this case decided 3 years imprisonment. After this assessment, the man was sent to prison, okay, with a brain disease. Okay, so I'll leave the discussion for the end. We'll go into case number 2. 74-year-old man, married, father of 6 children, retired professor. He's got hypertension and diabetes, also complaining of memory, and he gets sometimes disorientated. And he exposed himself to his grandchildren a number of times. That's the legal issue. He was also arrested when the family found out. And again, they requested a medical evaluation. Here, have a look at his clock, and you'll see again, well, you're already quite good at this, 12, 13, 14, 15, 16, 17, and then he went 18, 19, and he's also, you see the little strokes on the outside, he's also perseverating. A very similar type of clock, and you see his ability to construct the intersecting pyramids is not good. Okay, pentagons. So we did a further test, computerized cognitive test, and found major problems with inhibition. And here, have a look at this guy's frontal lobes. They've gone. He has no frontal lobes. They've all degenerated. So again, this is clearly a frontal lobe disease of this patient. He was given by the court 18-month probation and was allowed no contact with his grandchildren, which is a terrible thing for a family. And my final case is an 80-year-old man, married, father of 6 children, retired businessman, who has known Alzheimer's disease. He's confused, he's aggressive, and he demanded from his wife his marital rights many times a day. Okay, she's also an old lady, right? One day, being angry with his wife, he beat her with the cane and broke her arm, and she was brought into the ER, and the social worker convinced her to lay charges against her husband. So they called the police. Again, in his medical evaluation, if I'm talking about clocks, you see here a total disorganized clock. His brain is showing that he has no real order in his brain. And here, severe atrophy of the whole brain. The whole brain is disappearing. And here, what did the court decide in this case? To admit this patient against his will to a closed, in Israel we have closed units for the frail, cognitively frail elderly, which means he's in jail but looked after by doctors and nurses. That's what a frail unit is. So my final questions are, is the patient with brain disease indeed a criminal? Is the legal system adequately prepared for a growing number of demented criminals? And is there a need to establish specialized courts that have a clearer understanding of this type of situation? And indeed, how do we determine the intent of a patient with dementia? Thank you.